Good afternoon. This is Akram Zaaqoq. I am pleased to speak to you today about prone positioning during VV ECMO. I would just like to give a couple of minutes just to see if there is any other attendees who would like to join. All right. So I will reintroduce myself just in case someone joined. My name is Akram Zaaqoq. I am an associate professor of medicine here at Georgetown University, Washington, D.C. And I'm the medical director for ECMO program. It's my pleasure to speak to you all today about prone positioning during venous ECMO. I know this is the last session of the day. I promise you it's going to be a short session, and I hope you're enjoying the conference. So the objectives, I'm going to discuss with you prone positioning in general in the acute respiratory distress syndrome and how COVID-19 had an impact on prone positioning studies and what are the available evidence for prone positioning on ECMO, and is it safe to perform, how to perform it, why the patient on ECMO, and where are we heading with future research. All right, so the concept of prone positioning is not new. As you can see from this paper commentary, was written by Charles Bryan in the Blue Journal in 1974. He described in adult patients who are under general anesthesia with normal lungs, that is the best way to open the dependent portion of the lung is prone positioning. Couple of years afterwards, this study was done on the ERDS patients, and the data from this preliminary study, and I'm quoting the authors here, showed that 180-degree change in the position favorably alter the PO2 oxygen values and improve the mechanical toilet. Presumably, the increase in the PO2 was achieved by reduction of the alveolar arterial oxygen gradient with improvement of ventilation perfusion ratio. And the same study, if you see on your right-hand side, this is the circo-electric bed was invented in the 1950, and that use or recommended use at that time for proning patients with ARDS. Now, how does prone positioning work in general? This description from Gattonini, when he described the lung as being a sponge and the dependent portion of the lung in patients with ARDS become filled with a secretion and collapsed, as you can see down here. So if we prone the patient, so we put those dependent portions of the lung in independent and lift it up, that will help with opening these part of the alveoli and the lungs. And then with adequate PEEP, we can keep these alveoli open. Now, when the alveoli open in prone positioning, and that matches the blood flow to the lung, that's how we see the gas exchange improvement. But prone positioning doesn't just work in that way. It also works because it reduces the chest wall compression pressure and also distribute the pressure around the lung adequately and eventually reduce the effect of the mechanical ventilation on the lungs. In addition, prone positioning has hemodynamic impact on the right side of the heart. So it allows blood to flow into the right ventricle and then get pushed into the left side through the lungs. And as a result, that reduces the workload for the right ventricle and improve the patient hemodynamics. So as you can see, the prone positioning in patient with ARDS in general has multiple benefits. Now, when you look at the studies that was conducted on prone positioning for patients on mechanical ventilation, you will see there are multiple attempts of the RCTs, randomized controlled trial, since 2001 until 2013. And if you look closely at this table, you will see the first 3-4 trials, actually they all negative studies, meaning didn't show any improvement in prone positioning. But then when you look at when was the prone positioning started, some of the studies started late. Also, some study, the duration of proning was very short. And lastly, you will see also the tidal volume was relatively high in the earlier studies. So that's until 2013, when the Perciva trial in New England Journal of Medicine came out and hit all the criteria almost right. So they had initial initiation of proning within 36 hours with protective lung ventilation, and the extension with the duration of proning was 17 hours at least, or 16 hours at least during the day. And as you can see, the patient required proning almost like 4 days. So as a result, prone patients with moderate severe ARDS, they had improvement survival at 90 days. And now this is become the standard practice for patients with ARDS before they go on ECMO. So the way we look at prone positioning, it's more like a sound wave. When do you start it? For how long you're going to do it? What is the duration? What's the frequency you're going to do it? And then when you end. All right. What about COVID-19? COVID-19, as you're all aware, most patients we're trying, there was some resource limitations on mechanical ventilation. So there was multiple attempts to prone patients while they are awake or while they are on CPAP machine or high flow nasal cannula to see if that will impact their outcome. The first report compared patients with where they are awake patients, they are on high flow and had early versus late proning, and shows that the patient, if they were proned early, they have better survival benefit and also has better gas exchange. And in the study in between, which the awake prone positioning reduced work of breathing in patients with CPAP, this study shows if you prone patients with a COVID-19, there is reduction in the respiratory rate in those patients. And the last one showed if you prone patients on high flow nasal cannula, you will actually reduce the need for intubation, and also they will have better survival. But these reports did not last for too long, because afterwards there are 2 other studies came out, has a larger number of patients, and shows actually that proning patients, awake proning of patients, didn't have any impact on the survival at 30 days, and also did not really reduce the rate of intubation and requirements for mechanical ventilation. So as you can see, the concept of awake proning during COVID-19 is still not clearly delineated and understood. All right, what about ECMO? This study from the COVID Critical Care Consortium, it had 230 patients, and this is a retrospective analysis from multi-center all around the world. It's almost like 50 centers all over the world contributed to this study. And the good thing about the designing of that study that we looked at proning and supine, and we tried to mimic the patient journey during their hospitalization. Either they go from ECMO supine to ECMO proning and reverse, and then see if there is any effect on death at 90 days or discharge from the hospital. And as you can see here in this graph down here, that proning patients on ECMO was associated with reducing the hazard of death. So patients survive more. And also, the longer actually you prone them, the better is the outcome. And so that was very interesting study on COVID-19 patients who required ECMO. But the same signal came from another collaborative work where patients actually were assigned to prone positioning versus supine position. And as you can see, the same signal confirmed the same finding that proning patients had better survival at 90 days. And the results continue even with doing propensity matching between both cohorts. So this is another study confirmed the finding about the beneficial effect of proning patients with COVID-19 on ECMO. What about, is the COVID-19 unique? What about the ARDS? So as you can see, there is this study where they compared patients who had proning versus non-proning in general, in all ARDS patients. And the same thing, the same signal confirmed that proning is associated with improved survival and 90 days. So if you are doing prone positioning, when do you exactly do it? When do you start doing it? So this study compared patient with proning versus supine in patient with severe ARDS. And they try that the study was negative, actually, didn't show an impact of proning versus supine on survival at 60 days. But when they did propensity matching between the study, and they looked specifically at early versus late proning, they found patients who early proned on ECMO within less than 17 hours, they have better survival, as you can see here. And the same confirmation happened in this study, where they compared early proning when we prone patients within 5 days, early, less than 5 days after initiation of ECMO, versus late when it's more than 5 days. And the same thing, early proning is associated with better survival than late proning of those patients. All right, so so far we've seen multiple studies shows the impact of proning patients on VV ECMO, either in COVID-19 or general ARDS, on the survival and mortality. And we're also seeing that the early proning, the early initiation of this intervention is better than the late initiation. And this report here just focused on complication that could happen with prone positioning, meaning if there is any major or minor complication. And the overall cohort of the study, it has close to 230 patients. And the complication happened just in 21 patients, so it's close to less than 6%. And as you can see, most of the complication happened, it is minor complications. So this video here from Jordi Herrera and from Barcelona, and as you can see, I'm not sure how many of you guys do proning in your institution, But as you can see, this is the procedure, and you can see the team involved in proning patients on ECMO. It is labor intensive. It requires a lot of staff to be involved in. And it's a teamwork, and ideally require procedures or protocols and guidelines to be followed in which patient to prone. As you guys can see, the manual pruning is possible for these patients, but it's resource intensive. But I guess most hospitals during COVID-19, they had a team that's responsible for proning patients on ECMO. And usually you prone these patients and then you supine them. So you almost require the team to get together twice a day. In this slide, we have this paper here. We actually put step by step the protocol for proning patients on ECMO while using the ceiling left. And we use it in my institution. We didn't really have, we had very good luck with it. It's very easy. It's very easy to use. There's definitely complication that happen with proning, and these complications, but these complications most of the time are minimal complications. As you can see, it goes between bleeding from the cannula site most of the time. Of course, there are major complications could happen, such as the cannula obstruction, dislodgement, or breach in the ECMO circuit, of course. That's why it's important to train the team and get the team buy-in for these procedures and have well-set protocols for proning patients on ECMO. So if you decide to go that route, and I believe that every patient on VV ECMO with severe ARDS, they should be proned. Except one condition, I'm going to mention it to you in the end. Well, of course, except one condition, but then of course, if the patient has contraindication for proning, you should of course avoid proning them, meaning if there is like, trauma patient with spinal fractures, increased intracranial pressure, open chest, etc. But I like this slide because it set the structure, and as you can see, there are a lot of barriers to mobilizing patients, and almost the same barriers are, good apply for proning patients in general in the ICU. Meaning, lack of the adequate staff, training of staff, the equipment also very important. And then also, does your institution has the culture of proning patients of ECMO? And do you have the knowledge of the staff? And when you try to prone them, do you have there is a plan and coordination between, the team member, and what are the expectations, the rules, what if something wrong happened, how to deal with it. So as you can see, it requires really a lot of coordination and training for the staff, because those patients, they are sick and they're unstable, and there are a lot of medication, and now they have a lot of tube and devices going through their body. So, in my opinion, which patient you shouldn't prone? I mean, if you have in your institution the culture that you provide awake ECMO, where you wake up patients and you get them moving, I think that tips, the benefit of proning. Because most of the time when we prone patients on ECMO or even on mechanical ventilation, they are heavily sedated, and probably they might be on neuromuscular blockers, just for the comfort of the patient and stability. And we don't know what are the effect of the long-term sedation on these patients. And from other studies, we can tell, like, those patients, they on the long term, they come with a critical illness. They develop, myopathies. A lot of patients, they come afterwards and they have some sort of emotional distress about their experience in the ICU, and PTSD and other complications. So yes, we know there are benefits for proning patients on ECMO. And this benefit, as you can see from the studies, is reported into like 60, 90 days, which is short-term benefit and survival benefit for those patients. But yet we don't know what are the long-term outcome for these patients. And as I mentioned, lifting sedation, mobilizing patients probably has a huge benefit. And of course, we don't have really comparative studies to say which arm is better on the long term. And these are the summary slides for my talk. Prone positioning is beneficial, but we should have, established place to ensure safety and reduce complication. And we're not clear about the long-term outcome for patients on ECMO. And with that, I'm happy to answer questions. I have a question from Mohammed. Any difference in the outcome of proning between awake or sedated ECMO patients? We don't have studies really about, proning patients on ECMO while they are awake. I think that would be versus sedated patients. According to my knowledge, most patients we have, they are sedated when we prone them on ECMO. Another approach you can think about, if you have a patient who is ARDS patients on VV ECMO, you can have it as a timeline. As you can see, early proning is beneficial in comparison with late proning. So if you're not able to wake up the patient, most of us were not able to wake up the patient in the first 24 hours or 48 hours or up to 72 hours even. Maybe at that point, you consider proning them for the time period. And then when you supine them every morning, you can do your sedation vacation, assess the patient neurological status, and assess the patient for readiness to be extubated and mobilized. How many of your ECMO patients are you proning? So during COVID, early on, we proned, so we did almost like 50 cases. Early on, we proned almost 15 of them. And then we stopped proning for staffing issues. But as I mentioned, in the ideal world and ideal situation, you would like to prone everyone. Some ECMO centers are still against proning on ECMO. What approach would you take to make a shift in practice? It is, it's a labor-intensive intervention, and the change in the culture will require a lot of sharing of the knowledge. There is actually a randomized control trial coming now on proning patients on ECMO. And I think the challenge you guys as being, you know, the ECMO specialist and in the ECMO field, that we have new evidence and we have to take that to the team and we have to discuss what we know with them and, you know, come with a system approach to deal with these patients. I think that's the way to do it. You know, if I think we all in the medical field, if we know any intervention will be beneficial, we'll definitely adopt it. Sorry, David, that's the best, you know, answer I can give you, but I know it could be challenging also. Why not go directly to ECMO and bypass proning, reducing the need for sedation and paralytic? I love this idea. I mean, I love the idea about, like, you know, cannulating patients early on before even going on the invasive mechanical ventilation. I think this is the new algorithm. And Mario, if you've been to ECMO or, like, you know, other ILSO meeting, that's the discussion where it's going, you know, that we should use ECMO for the injured lung, if you would say, because we know mechanical ventilation comes with its downsides and effect and might prevent the healing of the lung on the long term, on the long run. So this is what we talk about, the paradigm shift. You know, in patients with acute lung injury, you know, hopefully we can see in the future this shift where we go directly to ECMO and avoid the whole mechanical ventilation, proning, and all other interventions. So I agree with you. I think it's a good idea. You know, I wish there is a way actually we can, you know, conduct a study like this. We have some reports, you know, as you all aware, came from the French institution about just going directly on ECMO. And, you know, they report actually good outcome with that patient experience. The only challenge we go if there is a pandemic or anything, we have more ventilator than ECMO machines. So hopefully the industry, and I hope some of the industry friends will be listening to this, can help us to have affordable ECMO machines so we can advance the knowledge and, you know, and advance and increase the number of the ECMO centers. So then we don't need the mechanical ventilation anymore. All right, I know I kept you guys too long. I really appreciate you all being here. And please feel free to reach out with any question. I'll be sure that the course coordinators, they have my email. And you all have a nice evening and continue to enjoy the conference. Thank you.